want to talk about trustworthy guidelines. Can we prepare them? It is a big question. Everybody thinks they can, and everybody believes what they do is the most trustworthy part, and they are the most accurate person. So this is my disclaimer. Josh showed that I was still an AMA delegate. I am not, and Lee Snook is the AMA delegate. He's sitting here. He's took over. It is not an easy job to be an AMA delegate. You have to spend boring hours there. I would say almost hundreds of hours per year. So I'm so glad he took over that. The only two positions I have now is the Kentucky CAC and Casper Drug Abuse Task Force. I do a lot of other things, but I do receive royalties for my publications, the books, and I'm also a consultant for Centene Corporation. It is a Medicaid managed care, provide guidance to them, and I'm a reviewer for Maximus. There are no outside grants, etc. And if you buy EMR, if you look at that, I do own 20% of that EMR. But by the time I receive what I put into it, they have to sell about 1,000 of them, then I will break even for my money, so no big deal. Okay, what is the trust and what is the guidelines? So it has to be worthy of trust or belief. It has to be a trustworthy report, reliable source of information. It has to be dependable, faithful, honest, responsible. Just sounds like a spouse, right? And the guideline is, it is a statement by which to determine the course of action, streamline a particular process according to a set of routine or practice, but guidance is not mandatory or binding. So I want everybody to just remember this quote and go home with this. Write it down or whatever you want to do it. This is the most important quote in your lifetime you will ever hear. This is the most entrenched conflict of interest in medicine, is a disinclination to reverse a previous opinion. This is the most important part. You keep trying to protect your previously said opinion, and you never look at the evidence. That is the major bias. So what is accountability? It is not independence or independent of accountability. That is what our independent doctors say. I'm independent. You're independent of what? Accountability, probably. So you need to be transparent, consistent, and independent. Prepossession, the mental phenomenon whereby when we seek the evidence of our preconceptions, we are going to find it. Vagary, the obsessive pursuit of a particular conclusion decided upon early, whatever the contrary evidence is. How do you rationalize? The intellectual art of piecing together valid experience in such a way as to produce an invalid conclusion. Congeniality of conclusion, whereby we reach the conclusion we like rather than one dictated by evidence and logic. So this is what evidence-based medicine is. We have looked at that. And these methodologies don't understand comparative effectiveness research. This is comparing two treatments. So you cannot have difference if both treatments work between the groups. You can have difference only within the groups, not between the groups. Why is EBM so hard? Because we always overlook the obvious. It is like, it looks like a duck, quacks like a duck, but usually we used to, it is a duck, but now we are questioning, what the hell is it? So evidence-based medicine is like religion and politics. It is in the eyes of the reviewer. So US Constitution and evidence-based medicine have a lot of similarities, I think. Constitution is not an instrument for the government to restrain the people. It is an instrument for the people to restrain the government. Now, the same way, EBM is not an instrument for non-coverage and cost savings, but it is an instrument to provide best treatments. How do we apply EBM? Everybody applies it differently. David Eddy, again, conflicts of interest. He was supposedly quoted everywhere and everything, but he has his own company selling the EBM products, how to derive EBMs. So methodologists, when there is evidence that something works and benefits the patients, we should do it. That is a great thing. But for the counteraction for this is nothing works, so you can't do anything. When we don't have any evidence, you should not do that at all. So, but some of us don't want to follow this either. We just want to go ahead and do it. It works in my own impression. When there is insufficient evidence, we have to be extremely careful. This is a really good quote, but some of us ignore, and methodologists also ignore. So maybe someone can help quantify the value of your research and development work. The only people who can quantify the value of research are liars and morons. Maybe we could hire a consultant that just turns a liar into a thief. So this is the science of methodology, EBM, and clinical experience is the most important aspect of that. But that is completely eliminated now in the new paradigm. That clinical experience, most important aspect, is completely eliminated. Lack of evidence in the literature is not evidence of lack of effectiveness. We all know that, right? We must remember, absence of proof is not the same as the absence of fact. It simply demonstrates the lack of adequate research. So what is EBM? Clinical experience is making the same mistake with increasing confidence for an impressive number of years, perpetuating other people's mistakes instead of your own. That is what evidence-based medicine is. So we even changed the definition of a clinical practice guideline. This was the clinical practice guidelines in 1990 were defined differently, and we have a more recent definition which just came in September of 2011. This says, are statements that include recommendations intended to optimize patient care that are informed by a systematic review of evidence and an assessment of the benefits and harms of alternative care options. So these trustworthy guidelines are based on systematic review of the existing evidence developed by knowledgeable multidisciplinary panels. They have to consider important patient groups. They have to consider explicit and transparent process, which we don't have. They have to provide a clear, logical correlation between the evidence and patient response. So these are the bullet points IOM gives, and CDC or anyone, nobody wants to follow them. These are all their own organizations. They still don't follow them. These are all government funded. We are paying for them. So this is the beautiful graphic they provide, IOM provides. There is a clinical problem. You assemble a multidisciplinary team. You develop systematic reviews and produce the report. Then you do the appraisal of the systematic review. Based on that, you develop clinical guidelines, and patients get better, theoretically. But we don't have any proof for that. So we have to know what works in healthcare. Again, another IOM document recommended that Congress should designate DHHS a single entity, a program with authority. We need another agency for this now. Again, they talk about conflicts of interest and everything. So to look at it, do we have a gold standard or is it a tarnished silver? What is it for guidelines? We don't have a gold standard, and it is not even a tarnished silver. That is beautiful gold, right? You better buy some and keep there because our dollar is falling like a rock. They have to be valid. The attributes reliable and reproducible. They have to be applicable clinically. There should be clinical flexibility. There should be clarity. And there should be a multidisciplinary process. You also have to have scheduled review. We talk so much about APS guidelines. They expired. They don't even work anymore. The maximum life of a guideline is, unless it is a very well-known topic, it is 3 years. It has been 3 years since they published, so they are gone. You have to document. This is tarnished silver. All the guidelines have a lot of problems. They looked at various studies showing that these guidelines don't meet the criteria. But who is looking at it? Are they really looking at the whole stuff, or part of the stuff, or just like the systematic review they did? So only guidelines which really is used very well is the cataract. And hypertension, CHF are pretty good. Colorectal cancer and bronchial asthma gets above 50%. But again, I don't even know if these evaluations are trustworthy. There are a lot of deficits in all our guidelines. And statement of fact is not a recommendation. When you read the CHOP guidelines or any other guidelines, they give you the facts saying that that is not a recommendation. You can't. Now, if you say that steroids and local anesthetics work or produce the similar results or same results, Mark wrote an editorial one time, long time ago, or a few years ago, not long time, that there was no difference between local anesthetic and steroids in epidurals based on the studies we were publishing at that time. So that is a statement. He's not saying that it doesn't work. And he's not saying you should not use it. He just made a statement that both of them are equal. That is a statement of fact. The next comes the recommendation. Here, they are saying because both are equal, it is a placebo response, you should not use it. We have this AWOL, ambiguous, vague, and underspecified language. We see this all the time. Deliberate vagueness and underspecification, insufficient evidence, inability to reach consensus, a lot of legal concerns. What are we obligated to? If you show more than 50% evidence, you should try to give that treatment to the patient. If not, no. You have to have your measurements, outcomes. Authors should be very explicit about when this treatment should be used and who has to use it. So a neurosurgeon, that is a bad example, but anybody, if they don't have any knowledge of the procedure, they cannot use it. They want a transparent process. Evidence of quality appraisal. Lee was trying to show me that there are other evidences we can use. I know Lee, there are about 110 of them now. In 2002, there were 82. Now they have more than 110. Recommendation of strength for dummies. If it is a positive outcome and good quality evidence, you do it. If it is a negative outcome, risky, and low quality evidence, don't do it. You can't implement the guidelines most of the times the way they are written. They are not very clear. They also recommend a platinum process. There is a NHS accreditation process. We looked at it. It is awful. They really don't even look at properly at the guidance or who does what. Guidelines are expensive. This is Chow's quote. They said each systematic review costs $300,000 to $400,000. I think that is BS. So ACIP guideline process, we just follow these guidelines, even though they are questionable. Systematic reviews, randomized controlled trials, observational studies, and diagnostic accuracy studies. You need to look at, in randomized trials, source of risk of bias. That is one of the things we do for each study. This is for randomized trials. You assess the quality of the manuscript. If they score 50% or more, it is called with low risk of bias. If it is less than 50%, it is high risk of bias. There is a PRISMA checklist. You have to look through this if you really want to do a good systematic review. You have to follow all the steps. Observational studies. A lot of them say observational evidence is good, but they never include them. And they never provide you any evidence base at all. So they can be evaluated by various means, about 80, 100 of them. But this is the one NHS, that is from England, recommends. So we have been using this recently. There is also a systematic review of observational studies called MOOS. We have diagnostic accuracy studies. We are using this new list called Quarel, and Bogdock was involved in this, so I think it should be good. So. It shows methods of, finally we settled on this, methods for grading the overall strength, because they were criticizing us for doing a different one. This is what they are using, so we thought we'll just use this. It is only 3 levels, good, fair, and poor. So we added limited to that instead of saying poor. You can't say poor for everything. It is limited. Actually, Lee is the one who brought that point up to me, so we changed it. These are the folks who are involved in spinal interventional techniques guidelines. These are the steps to completion of the timeline. These are the systematic reviews we have been planning on doing. We have only like 12 completed so far, 5 published and 12 completed, so we still have a lot of work to go. We also have the opioid guidelines. These are the folks who are involved in that. And we came up with all these conclusions. I don't have time to go through over that. But the most important thing is we are trying to recommend the low dose, moderate dose, high dose, as this is only preliminary, so don't get upset. So if you have opinions, you can give them. It is up to 40 milligrams is considered as low dose, morphine equivalent, 41 to 90 as moderate dose, and over 90 is considered as high dose. So trustworthy guidelines, maybe we can prepare. Yes, no, maybe. Thank you.